Harish?
If you don't have modular stems in the revision system and you have only the monoblock which you use, either monomode or Wagner, is it okay to do a, say, elective, deliberate long trochanteric osteotomy, open it up so you can get distal access, good fitting? Osteotomy may not fit well, it will be fitting little out, but what other option will
Absolutely, that's the other strategy. Yeah. So one thing you don't do is when you want to use a long monoblock stem with the endofemoral root, you don't put a long stem inside. You will not get rigid fixation distally. The way of handling is you have a very curved bone, you divide it into smaller, straighter segments, and once you do a ETO, it becomes a straighter segment, and then you can get a monoblock. That's actually the other strategy when you cannot afford a modular stem.
Hi, this is Dr. Rohit. I just want to know, can you predict the substance of these stems and how to avoid it? So in case, is there any tip to avoid it, and how in watch patients can you predict that it's going to subside and you want to go up one side up? You know, so sometimes you are in dilemma because the trial broach and the final stem, you know, there's a little one size up. So for surgeons who are starting new, so we would put a cable, but how do you predict?
So the substance is because of three reasons as I enlightened. One is that the single step, if you want to restore soft tissues, typically the mistake the surgeons make is that when you're using a monoblock stem, you have done your soft tissue stability, you want to leave a stem in a particular place, and you are putting the final implant, it's still not seated fully, and you say, I cannot go any further, I will lose my stability. So you stop there, and then post-op it subsides, and that's the usual reason why it subsides. So either you use a modeler and get distal fixation first and add on a modeler component, or you use the monomod and do it with separate steps and try to get very rigid fixation. So that's it. The monomod comes with a shoulder marking, very accurately you can match it, and that's the advantage of the new marking system that we have. We are able to very closely match, and to the best of my knowledge we have not had any subsidence with this.
Do you have any comments with regards to hand reaming versus power reaming?
Absolutely. I think how they have fluted tapered, although Heinz Wagner interestingly said that you must hand ream, once you come to the diaphragm, which is cylindrical bone, you have to get your fluted tapered titanium stem into a cone. The diaphragm is the cylinder. So the only way you can convert the cylinder into a cone is by power reaming. So we recommend power reaming in every single case that you are going to do, where you are going to convert the cylinder into a cone and then put a stem inside. So power reaming, so at least your last reamer you must do with power, and that's a very important point I think in all these stems.
In our situation, in most of the cases where the failed IT fractures after removing the implant, we tend to use this Wagner stem. How do you find the usage of monomodular in that situation? Is it helpful? And
well, it is no different apart from the fact that we think it will have a lesser rate of subsidence. So only time will tell, but we think it will have a lesser rate of subsidence, but otherwise it's going to be just the same. Yeah, Anup?
Yeah, Vijay, monomod stem has been in use for last 4 or 5 years, I believe.
3 years.
3 years. Have there been any cases reported of this fracture of the stem?
No, we have not had any fractures, and to the best of my knowledge, we are trying to get that. We have not had at least any reported case of subsidence, significant subsidence.
Yes. No, the point I was trying to make is I believe it's being exported to other countries also. So there has to be some mechanism by which Merrill should be able to. Yeah.
Absolutely.
The subsidence is definitely less as compared to the Wagner. The monomod subsidence is definitely less, and the preparation is easier. As you explained, well, the preparation is definitely easier. Once you have started doing the monomod stem, I think I have not gone to the Wagner as well.
Yeah, I think you're onto something with the 2.5, right? 3 may be too much in some situations. Yeah, and I think what we need is choices, right? Like it's not the modularity of it, but what's the taper angle you're getting.
Absolutely. Yeah.
Microphone 2.
So in a short stated female, we see sometimes when we have to revise, the amount of isthmus that you have is very small, and if there is a crack around the isthmus when we are reaming or when we are trying to ream, then what is the bailout in such situations?
Well, that's a very tough one, and it's not uncommon that we see this short female patient with the board femur, and even the 190 stem is the shortest stem that we have is inadequate in many cases. I face this problem quite a thing. Then we need to do some kind of an osteotomy and put a longer stem in young patients, which is a very wrong thing to do, but we have no other choice, and that's why we have now developed the next, the adjunct to the monomod halo, which stands for the hybrid Asian low offset. So it will be much shorter than not much shorter, shorter than the 190, where we can handle this curved proximal bone, and also the offset is very high. typically all revision stems will start with the offset of 40. Typically all. So even the monomod starts with 40, but with the halo, you start with 30. So we'll have a range between 30 and 40 to specifically address our patients.
Thank you, sir.
Just to take that question forward, so with the monomod, sir, if you run into this problem, would you ever do an anterior-based ETO with the risk of still having abductor damage to the Wagner's ETO?
Anterior based. So I think you should not disturb the abductor mechanism, which is lateral. I know Wagner described the anterior 1/3, but the philosophy now after Paprowski modified it, the abductor is lateral, and that's what you want to take away. You don't want to go into the abductor at all. So I think the ETO must be lateral.
So you would not use this as a bailout?
No, I won't use it.